Hello, and welcome to another episode of the Everyday Leader podcast. I'm your host, Dr. Ananya. I am here today with Dr. Richard Gardner, who is a pediatric orthopedic surgeon and assistant professor at Sick Kids Hospital and the Department of Surgery at University of Toronto. Always excited for all my guests, but Dr. Gardner is a special one because he's my teacher and my mentor. So I'm so excited to have him here. Dr. Gardner, I'm just gonna call you Dr. Rick, like I always do. So welcome to the Everyday Leader.
Yeah, thank you. Thank you so much for having me. Excited about this.
Yeah. So we're just gonna start off as we usually do. I always like to hear what the phrase Everyday Leader means to our guests. So what does the phrase mean to you?
Oh, that's a great question. I think it's really leading, kind of regardless of position or any power differential. I think it's really working with compassion and integrity and supporting those around you, and maybe showing another way of doing things, which is possibly against what may be taken, whether you're in an office culture or in a healthcare culture. But really encouraging others, working alongside them. If you're in a position of leadership, I'm a big fan of the whole servant leadership concept about really pushing others forward and not trying to be the big boss, but working them alongside your colleagues and just trying to help them be the very best they can be and have the most amazing careers and pulling together as a team. And I think amazing things then happen. I do love the word. I haven't come across that word before you said it, Anya, but it's I do love that concept, and I think for me it's probably wrapped up in some of those things.
Yeah, I completely agree. The servant leadership style, especially, I think it's not celebrated enough because as a leader, we always have to remember we're there to empower others or the team around us, not just to demonstrate our efficiency or our abilities, because that's easy to do, but it's harder to actually help other people around us meet their potential, and then build something sustainable, because that's the only way to build something sustainable. So I love that. Thank you for reminding us of that. So what I'm gonna start from somewhere in the middle, because I think you've done so many interviews and you have talked about how you got to where you've gotten to, and I want to get to the meat. So what first drew you to work in Africa, and did you have any mentors or moments that shaped your paths towards that sort of missionary work?
Oh yeah, no, thank you. So I think the actual to move overseas and to live in Africa and the joy of being there for many years, my Christian faith was a big part of that decision. And I think probably coming alongside that, probably two other things come to mind. One of them was just, I think in my teens and early 20s, I traveled a lot, really through Asia and Indian subcontinent. And I had the opportunity to volunteer with some different NGOs along the way. And really, I think then I had a sense of what true vulnerability really means. And, the more I would visit different places and work with some different organizations, a sense that if I was to go back and work in my children's hospital in the UK, where I did my training, there's probably 50, 100 other people who are just as qualified as me to do the job. But then to work in other environments where there's less straightforward access to healthcare, then actually maybe I could make a difference and be a part of something bigger than myself, is to kind of make a positive difference. And so that really spoke to me alongside some amazing mentors. So you're talking about mentorship. In my early residency, I went to South Africa, to a place called Umtata, which is in the far kind of eastern Cape of South Africa. well away from the kind of relative wealth of the Johannesburg and Cape Towns, but in an area where a lot of the similar issues that you've experienced for many, many years in Ethiopia, Nanya. And they'll work with a man called Chris McConaughey. He's a Scottish orthopedic surgeon, his wife Jenny, and he had been there for 27 years providing healthcare to, I think, a catchment area around 5 million people. It was a little hospital called Bedford. He converted it from a TB sanatorium into an orthopedic hospital with 4 operation rooms and I think 50 or so beds, and provided just incredible healthcare for a really vulnerable population, both for trauma cases, severe infections came in, lots of children with different conditions. At the time, it was really a peak HIV pandemic without really any treatment. There was lots of tuberculosis of the spine, children coming in who are paralyzed and incontinent, and through he went in through the chest and did the old Hong Kong procedure where you kind of open up the side of the do a thoracotomy, and the big paravertebral abscess, he decompressed that and then put in a rib strut graft and then did a posterior fusion afterwards. And amazingly, I audited that and actually ordered the children who came in incontinent paraplegic, walked out of the hospital at the end of 6 months. And I just thought that was just totally remarkable. And he was such an inspirational man. And although he didn't have all the resources and the facilities he wanted, he had a real adage of we just do what we can. And that's not to say we should compromise on care. It's to say we should do everything to the utmost of what we're able to do. And was really a big figure and a big sort of flag in my life of what could be. And then some years later, you mentioned Malawi. I spent a year working in Malawi really as a trainee, as a sort of I see in many ways my first fellowship program. And then I came across this organization, Cure International, which has been a big part of my life for the last 15 years. And the Bike Cure Hospital in Blantyre, Malawi, at the time had 4 amazing surgeons: Jim Cashman, Jim Harris, and Nick Lubega and Sam Miner. 2 Englishmen, 1 Ugandan, 1 Kenyan. And here children were coming from all over the country. And I think Malawi's got a population around 16 million. At the time, they were the only children's orthopedic surgeon in the country. And children were coming from all over with some of the most complex conditions that I had seen. And they would be treated with a level of skill and excellence and care that was just honestly remarkable. And it was a well-resourced hospital. It's got a strong Christian influence to that. And actually, that was really just shone through everything that happened, and really was just a pillar of excellence for the region. And I learned a lot there. And I was totally hooked. And I just thought, actually, what an amazing way it would be to have a career doing that kind of work.
That's amazing. I love that you mentioned that faith is an important factor in all of this, because I am one of the people who believe that, miracles can be performed through love and compassion. And that's what, as human beings, that we have, we can't put our hands and heal someone or speak and heal someone, right? But through the love and compassion, and then putting in our skills and knowledge, then we can do miraculous things in people's lives. So that is very important, and I think it is central to a lot of successful people that I know, at least in the medical field. So I love that. And exposure, like you said, when you were really young, you were exposed to a lot of things, which gave you a perspective, because you could have stayed in your comfort zone, where you have stable electricity, good internet. I mean, you know what I mean? Like good healthcare, because when you move to a resource limited country, then it means you're also compromising what resources you can use, right? And your family can use. So exposure is very important. And I think we need to do more of that for the younger generation as well, to instill, like you said, vision and purpose. So just piggybacking on that, you have served vulnerable communities everywhere you go. Not just the fact that it's in a third world country or in a resource limited setting, but also usually it's the hospitals are not like in a capital city, or even if they're in the capital city, they're not flashy hospitals. We've seen the Cure hospitals. They're very clean, very basic infrastructure wise, but very well equipped at the same time. And then you're also serving children, and not just children, but children coming from the poorest part of society. So it's one layer to another of, emotional trauma, just being exposed to all these things. So how do you stay grounded amid this, the suffering that you witness just because of your work? And you mentioned faith. Does faith play any role in that, or do you have any other personal philosophy or group of people that keeps you, balanced, that you can keep your emotional stability?
Yeah. Well, no, thank you. It's a great question. In many ways, I'd love to see how you do. But you worked for many years leading the program in Gondar in northern Ethiopia during wartime, and so I'll offer my sense. But I'd love to hear about how for you, which I think was a far more challenging environment. But for me, so I arrived in Ethiopia in 2013, and at the time, you'll remember there was sort of less than one orthopedic surgeon per million of the population. I think maybe there was maybe half, as it were. For 120 million, I think that we had 60 orthopedic surgeons. And that did seem to be insurmountable, the idea of how on earth we could ever build any level of children's healthcare, not just within Addis, but let alone outside of the country. And that came around about the time of that huge explosion in residency training. You'll remember very well, Ananya, and you were one of the stars of that. And actually, that just brought so much sort of hope and excitement of just seeing a whole new generation of really talented young orthopedic surgeons who are keen to provide the highest standard of care. And actually, for our little hospital, Cure Ethiopia Children's Hospital, to have a relationship with the Black Lion Hospital, and then later on St. Paul's, and then University in Mekelle and Hawassa, and having trainees coming through and actually working alongside you and providing care to these children who would sometimes travel for 5 days to come down. I think in many ways it was much easier for us because we had a well-resourced hospital and had the equipment that I needed to take care of the children. There was a huge waiting list, and we would do outreach trips to some of the different university hospitals and try to sort of meet the children closer to their homes, and then schedule surgeries and try to diminish some of the burden that many of the families had for making trips to and from Addis Ababa. But I think the joy of working with yourself and your colleagues and developing that residency program and the fellowship program and having, amazing consultant colleagues to work alongside. There's a real sense of just kind of a combined shared vision and purpose. We had fellowship program where our fellows are now in, I think in 4 different cities outside of Addis, to a point that actually it's much more sort of, it's getting to a place of having more kind of regional referral centers for children's orthopedics. And so absolutely huge need, but then just every month, every year, just getting one step closer to really working alongside just amazing Ethiopian colleagues to develop a more comprehensive children's service. And, that still has another generation to come to fruition, but it was wonderful to do that and to be a part of that. I reflect on you going back to Gondar, where you started the first full orthopedic department in a very historical city in Ethiopia. And I think, if I remember the timing, Ananya, that was there was quite a lot of conflict during that period as well. And I think you were totally overrun with acute injuries, which I can only imagine the resource limitations that you had to endure. So I think you're far better placed to answer that question than me. What would you say to that?
I don't know if I'm at a far better place, to be honest. But also, for the most part, it was extremely stressful because you, as the only orthopedic surgeon, and then we do have general surgeons helping us out, on general surgery trainees helping us out, but you're on call 24/7. It does not stop. And like you said, there's resource constraint in order even to provide the level of care that you would want to provide. So that's very stressful. And I have always been honest about it. It caused me burnout. I had to take time to recover from that, to the extent where during COVID, we still had conflict going on, and I was forced to work. During that time I was pregnant. I was forced to work with a C-arm while pregnant because there's nobody else to do it. So like sometimes, it's tricky when you want to help people and you also have to have your own boundary, but sometimes you don't draw that boundary early on, or you're too young to realize, oh, if I do that, it doesn't make me a bad doctor or a bad person, which you realize later on. But that was a lot of risk that I took on my own life and my child's life, despite during such instances that I now look back and regret, but have learned from. So yeah, it is very stressful, but you live and you learn. But I think as surgeons, setting boundaries for our mental health and physical health while still helping others is very important. And I think as teachers, we need to teach that instead of celebrating being selfless. No, because that is not going to give you longevity. You're going to get longevity as long as, you set boundaries and you take care of yourself and your loved ones as well. But I asked that question because I remember one day you were in clinic and at Cure, and I was with you, and this kid comes in with, I think, his relative, a little kid with neglected clubfoot, which you guys treat a whole bunch of, and he was top to bottom covered with dust, like just dirt. And I wanted to ask, and you were examining the kid, so I just kept quiet. And then at the end of your examination, I asked the guardian, whoever brought him in, I was like, "Why are you both covered in dirt, like top to bottom?" And they said they come from a long way. His parents wouldn't get him treated. So this relative of the kid just decided, I've heard of this place, I'm going to take him to Addis. He brought him to Addis, but they used up all their money to transport to get to Addis. So they didn't have a place to stay the night. So they stayed outside of the hospital compound in the open. And you remember how cold that area is? It gets really cold because it's like a bit higher
So,
altitude. Yeah, and then they were sleeping outside, and there are hyenas and everything around there. So I was teary-eyed. I wanted to cry, but I was like, "Oh, okay, you were handling it so well." So I was like, "Suck it up, suck it up." And I had to suck it up, and I kind of cleaned my eyes. I don't think any of you have noticed, but I was like, oh, that was the most horrible day of one of the most horrible days of my life. So seeing you just calm and collected in such situations is the reason why I asked. So yeah.
I hope we admitted that child for then and there, did we?
Yeah, you did what you always do,
Yeah.
Yeah.
It's and actually you raise so many great points. Just the journeys people have to take. Ethiopia is such a big country, and you'd be there sitting in clinic and saying, "Oh, where are you from?" And they'll say, "I'm from Gondar, northern Ethiopia," and you'd be factoring, or maybe that's a day and a half. But then if you say to them, actually, well, how long did it take you to get to Gondar? And then that might be another day and a half. But they say Gondar because that's the nearest city, and the costs of coming from the periphery of the country. I mean, you'll know better than me, Ananya, but my understanding was it could be up to like a month's wages on a labourer's salary to travel down to the capital city, and that could be a once in a generational trip. And the whole sort of concept of catastrophic expenditure is so real just for travel alone. And I think that whole aspect where you've got a child with, say, an untreated club foot, and they've used up the resource to come down, there was the organizer for Cure is able to provide free surgeries for children. And actually, I was so grateful for that, because even if you were to charge that family $100, $200, then they've come all the way down, they've got no resources, they'll never be able to pay that. And actually, that is just the fact of the matter where the disability of the child also compounds to the family as well, because sometimes people have to stay home and take care of the child. They can't go to school, and maybe they'll be ostracized, and having all the stigmatization of having a disabled or a child who with a disability, but one which is just inherently treatable. And I think just to go along with the whole aspect where you were in a kind of a war-torn situation of just being flooded with severely injured people in an overwhelming degree, I think the joy of working with children, and particularly with the sort of the treatable disabilities, is that you don't have to treat children right then and there. You can schedule that. Now, a child like that, I hope we admitted them and brought them into care and went through all of the, and then they went home and with the foot pointing in the right direction and in a good place. But actually, the whole aspect about treating for children to really give them a chance at life and not having them be left behind, there's so much that we can do, sometimes through complex surgery, but often very routine surgery. I mean, you've done lots of clubfoot management, and it doesn't take considerable expertise to do the casting, rotate the foot around and do a tendon transfer. But what a difference it makes for that child's life, where, you know, that vulnerability from having a treatable condition untreated, maybe always being in the margins of society and never being able to have a job and probably a family of their own, to a point of having fairly routine surgery, and that entirely changing for them. And that never gets old, being a part of that. So yeah, I do remember I remember you being with us, Ananya, and how excited we were that you were kind of considering also taking care of kids as well, and actually going up and taking on that department in Gonda was no small achievement, I must say.
Oh yeah. One of the I'm gonna be honest, one of the reasons why I never did peds was I was just like, my heart can't take it. Because I just, like I told you, we were in clinic. I was about to just cry. Like, if this is what I'm gonna get into, I'm gonna see this every single day. And I'm like, can I even take that emotional toll? So I swear to God, I I admire everyone who has the heart to do that, because I love helping children. And like you said, children, that's where you have the most impact, because you treat a 5-year-old, then that's for the rest of their life, you're going to make them a functional part of society, right? So that's huge. You change the entire course of a person's life. But that burden of seeing them suffer, I just couldn't do it. So we left that for you guys. So yeah, when I was there as your student, so did many of my colleagues. And to be honest, Cure was one of our most favorite attachment. Everybody was sad when you left Ethiopia. We still kind of feel a little betrayed, but we're not going to go into that now. So anyone who knows you, can attest to the fact that you're a phenomenal teacher, a great boss to work with. How did you develop the art of teaching? And how do you think those same skills translate when it comes to leadership?
The mentors I had were a big inspiration to me. I think never quite letting go of my own personal frailties. And when I took longer to learn something than boss considered I should, and just recognizing we all live in a very glass house, really, particularly as surgeons. I mean, it's a very humbling career. Sometimes you might think you've done a wonderful operation and then a complication can happen. And I think as the years go on, we get better at making sure we're choosing the right operation with the right person, executing it well, and I think our outcomes do get better. But actually, things can still go wrong in surgery. And I think recognizing that personal frailty is always very helpful, just to, really come alongside people who are starting off in their career. Honestly, I've used the word joy a lot, but the joy of just working alongside talented Ethiopian trainees, and it's a team sport in surgery, and then you're taking care of these children and straightening out legs and straightening out feet and putting joints back in and teaching them how to do that. And how do you do that well? I think that there's a level of pushing that we need to do as trainees to make sure people prepare. And if they're coming to the operation and haven't read about it and haven't met the patient and got an operative plan, then they're probably going to be holding retractor for that operation. But if they've come in to say, actually, you know, I know exactly what I'm going to do, I know the approach, I've thought about it, I've done this, it'd be like, excellent, right, you're ready, and I'll stand alongside you and we'll do this one together. And I think that sort of understanding of accountability, I think, is very important for the young surgeon to have. That wasn't very difficult, honestly, with you and your colleagues, because the motivation was huge. And so I think, and then I think it just goes on as you're building up surgeons and supporting them moving forward. One of the things that it sounds like you've gone through is sort of real challenges of kind of moral issues of just what you do when you've completely overburdened with conditions, and then how do you support yourselves and other colleagues to go through that. I came across recently a term which I hadn't come across, but I know very well, called second victim syndrome. I don't know if you've ever heard of that term.
No,
a colleague of mine here in Toronto said, Rick, I'd like you to come into one of the leadership sessions and then you can lead the session on second victim syndrome. And I said, oh, I'm really sorry, actually, I've never heard of that before. I think it'll be terrible at that. And she said, oh, just read the papers. And so second victim syndrome is what happens when you have a complication yourself. And of course, if something's happened to a child or an adult you're taking care of, then all of your efforts absolutely to be to everything you can just to get that patient through that and out the other side in a good place. And you often know, as you know, the patients who've had a complication far better than the ones who have had a very straightforward course. But there is, with that, a whole sense of you as a surgeon having, actually, I'm not good enough, or I'm never going to do that operation again, or almost wanting to kind of feel it's a severe personal failing and you're sort of shrinking away. But actually, it's those times when, you know, your mentors and your colleagues need to come alongside you and just say, actually, you know, you're a great surgeon and all of these things can happen to us all, but actually these are the things that we can come along, and next time you're doing that operation, let's be together and we can do that together and sort of work through all of these in a really positive way and to come out the other side stronger and to provide better quality of care for our patients. And I think there's a thing as a mentor and as a trainer to also support junior colleagues at times when things don't always go right as well. And I think sometimes we miss that. We sort of teach them good ways of doing stuff, but we're not always necessarily teaching them how to become mentors themselves, and also how you deal with things when life gets hard. And so I think it's a two-parter in many ways.
Yeah, makes sense. You're right. Second victim syndrome, is that what you said?
Yeah, no, it's a well-published term, but I hadn't come across it. But when I read it, it'll be like, oh, I know all about second victim syndrome.
Exactly.
I can talk very eloquently about that. I just didn't know that there was a term applied to it. It came along a bit later on.
Yeah, me neither. I'm so glad. I'm so glad you shared that with me, because now I know what it is. It does. It makes you, and especially orthopedics, because most of the surgical outcomes are visible. Like, they're grossly visible. They're either visible on an X-ray or they're visible on the patient.
You can't hide behind them. Yeah.
No, it's not like use the wrong stitch, but nobody's gonna see it because it's in the abdomen. It's not like that unless it leaks. Orthopedics is very it's very transparent, like you said. So it also makes you hold yourself to a level of to keep your skills continuously improved, because it's just so transparent. And for me, how I got over that, I think the second victim syndrome, is because when I was in Gardner, and like I said, there's nobody else. So when you have to do 4 or 5 bullet injuries every single day, operate, you realize, you know what, you just do the best you can with the resources you have, because you're just one person. So, and even though most of our patients are young, so they recover quite well, actually. But when you look at it from just the intelligence part of it, like, oh, this is what is supposed to happen when I do a nail or when I do this or that, and then it doesn't go as planned. It's very easy to put some sort of pressure on you and make you doubt yourself. But once you get exposed too many times, you get over it. So it was kind of forced out of me. I was not something I did intentional, but
yeah, it's really hard.
It really is. But like, as teachers, we really need to, I think we don't discuss enough when we're going through or seeing patients with complications, we're not open about it with our students. You know, I've seen one too many times. I probably have done it as well, is to just hide when we didn't do a good surgery, just like, nah, or give it whatever explanation instead of being transparent and say, you know, yeah, I tried my best. This happened. What can I do next time? Just be humble and, you know, share that experience with your juniors. So,
and also your colleagues, because actually being in a working environment where people assesses, but the tough stuff as well, the times when things haven't gone right, and actually to be in that open colleagueship is so vital, I think, for really good patient care. I think the departments and the units that really flourish are the ones that have that degree of open dialogue and trust amongst them. And for you to say, actually, this is a hard case, and can we do that together? And this sense of colleagueship, which when you're a team of one is impossible. But you know, the times when I'm working in environments like that, and I've had that in each hospital I'm working in, I'm really delighted to have that now, but it's not a given, and it takes work, and it sometimes takes somebody to step out and to be vulnerable in that way and to allow others to do the same. And I'm sure that's many managers and leaders outside of medicine will be saying, well, that's what we all have to do. But certainly in medicine, I think that's a crucial part of avoiding burnout, to you know, have great care for the patients who we take care of, and to have us all thrive and enjoy our work.
Yeah, 100%. So, you know, you've been trained in one environment, and then for majority of your practice, if I dare say, you've worked in a different environment, right? So, what should physicians consider both professionally and personally when practicing in environments that they weren't trained for?
Okay, no, that's interesting. So give me an example, just so I know where you're going with that.
So, for example, you were trained in the UK and then Toronto, and then you came and worked in Africa, and many different countries in Africa, different healthcare system, different cultural context, and then you started a family, you built a family, and now you've moved back to Toronto. So your kids have to go through that, your spouse have to go through all the changes, all these things. It's different experiences, both professionally and personally. So if somebody's considering making a move, whether it's from the global north to the south or the other way around, what are the things that they need to consider and prepare for?
Yeah, no, it's a great question. I think for people who are moving to work overseas, I think is just making sure you've got some great colleagues just to walk alongside you when you're starting off. Because the thing is, a lot of pathology in low income countries, they're really hard. I mean, late presenting, really difficult pathology. You talk about club foot. You know, club foot in most places in North America and Europe, when that presents, there'll be a few-day-old infant having some casting, and clubfoot in Addis Ababa could be a 17-year-old who's been walking on the dorsum of their foot all their life, and that is something that we're just not trained to treat. Dealing with levels of sepsis where somebody might be having a destroyed hip because they didn't have that emergent washout when they were young, or you know, a dislocated hip turning up for a 7-year-old when you're expecting to be a 7-year-old as opposed to a 7-month-old. So I think honestly a lot of humility to know that your skill set isn't adequate for an environment that you're just not familiar in, and not to go in there thinking you have all the answers, but to go in there with real humility, to walk alongside the local surgeons and spend, you know, a good amount of time. I had the joy when I was in Ethiopia working with Dr. Tedros and Dr. Mesfin and sitting alongside them and just seeing how do they take care of these neglected hip dislocations and late presenting clubfoot, and learning from them. And then there'll be some things which are on my skill set. And I say, well, this is how I do these. But so much of it was really asking them, how do they manage that, and learning from them. And then some of the skill sets which I could bring into that, then we work together and have that colleagueship. So I think that is really key. And even if we're having trainees going across, I love it when trainees from somewhere in North America or Europe are coming alongside, working alongside their equivalent level of training in that African city. And then they can just share all those experiences and develop friendships and just learn from each other. And I think really special things happen. So I guess humility is one, and I think making sure you're going to a place where you've got senior mentors and other people to work alongside. I tell you what, I had a bit of an imposter syndrome. I don't know if you ever had that, Ananya, but when I turned up to Ethiopia and we had all the complexities of the childcare, and then we had the adult service as well for hip and knee replacements and the like, feeling decidedly inadequate for the task. But really, it was through some great friendships and colleagueships it went so well. So I think then to come back on the other side, there's so much subspecialization, as you know. And so when you're coming back in, what are you going to be doing? And then, the fellowship training, there's amazing fellowships in Africa, there's amazing fellowships in North America and Europe. And I think that fellowship training would be a key part of preparation. How you move with a family and a bunch of children doing it well. I'd love to have solutions on that. I've done that a few times, and I don't think I've ever done it particularly well, but that's tough with children of different ages. But I think always making sure you've got a good amount of time to help them settle in. And I think for all of these things, I think you mentioned COSEXA, a lot of these sort of training bodies, the College of Surgery, East and Central Southern Africa, these are amazing institutions. You've got the West African College of Surgeons, but for people who are interested in coming across to work in Africa, to make those connections and just to get to know surgeons who are working and you can walk alongside and share skills. I think some of these platforms are amazing places for people to get plugged in. Lots and lots of opportunities, and I'd really encourage it.
Yeah. Wow. Great points. So on the personal side, just wing it. That's what you're saying. Just nobody has figured it out.
Oh, with children and moving and all the rest of it. Yeah, I've got no silver bullet there. I think that's sometimes not easy.
Yeah. Yeah, it's gonna be interesting because I know was it Jim Harris? His kid grew up in Malawi. Where was it? Somewhere big.
Oh, yeah, so Jim was in Malawi for 10 years, that's right.
Yeah, so he always says his son loved it. He was running with the kids. He grew up free. So it's very interesting to hear people like that, and they have raised their children in Africa, and to hear how much those kids love it. I think now that child is an adult and is back in Africa doing missionary work or something. So yeah, so you don't know the effect, like you said, you're just trying to figure it out. But once they're adults and make their own life decisions, that's when you actually see if you have done right or not, unfortunately.
Yeah, and I think within that, for our children, is just hopefully having them a sense of being comfortable in all sorts of environments, and sort of being really comfortable in whether Ethiopia or Malawi or Zimbabwe, but just having great friendships and great connections, whilst also having a new sense of home. We're trying to be intentional about going back, and so this summer my older two went back and they stayed with friends, and they did a camp for a couple of weeks in Zimbabwe, and I think all of those side of things, that being a very important part of their upbringing now, and something which wasn't just set aside and we're not going back, but for that to still be current and living and an important place for them is really key for us as well.
Yeah, interesting. And you mentioned imposter syndrome, which is funny because for me, I did experience imposter syndrome, but not because I went to a different country or a different system, just because I was a female. So in a very male dominated field, and not as much when I was in Addis, a little bit there, but I guess it was expected. But once I was a surgeon and I went back, I was the most junior. All of the people in my department were my teachers when I was a student there. And I was the only female and the only orthopedic surgeon. So it was like I didn't even know what I was doing there. It was imposter syndrome on steroids. So and then there's also the patients. They're like, a female surgeon, like what, so it was, I was being bombarded from every side. But like you said, you might experience that feeling of not fitting in, and just give yourself a grace. With it doesn't, you don't have to go overseas to experience that. It can happen right where you
Totally,
are.
totally.
Yeah.
How did you sort of get through that?
um to be honest, most of it is just it's just focusing on the vision. I guess my personality played a big role, because I am the kind of person who loves challenges. And if you tell me I can't do something or succeed in something, then it's I'll take it up on myself to prove you wrong. But I don't know if that's a good thing. I'm just saying that's who I am. So the more people were coming at me with that, I was like, oh, okay. Not only am I not accepted as per the standard of what an orthopedic surgeon should look like or be like, but I'm also going to do those things. So I think it played a great role in everything else I've done afterwards, whether it's the department, whether it's the residency
Mhm.
program, and things like that. Yeah. So you can use it to fuel your vision, but you know, yeah, you have to be a bit psychotic like me for that. um, so you've been exposed to both healthcare systems, whether it's resource constrained, or the healthcare system in the
Mhm.
U.S., U.K., and Toronto. I mean Canada. So what can each of the systems learn from one another? Because it always seems like one is bad and the other is the example of what the perfect healthcare system should be. So what can the systems, I don't like to see it that way, so what can the systems learn from each other?
Yeah, um, no, I think an openness for that. And if we're taking, for example, somebody from, comparing a high income to a low income setting, you don't have to spend very long in a hospital in a low middle income country. Say you're picking Ethiopia or another similar country, just to know the incredible skill set that is there, and how surgeons and clinicians just do an amazing job of working with less. I think there is so much kind of overabundance of access to care in the sense of imaging and different types of investigations and the use of X-ray and theatre you're mentioning, that actually when you don't have all of those things around you, I think our colleagues who are working in low middle income country environments, actually their clinical skills are rather finer than ours because they have to use them. Their ability to operate when the X-ray machine would go down, which was shut, would be doing any surgeries in a high income country, but actually knowing that they can perform really excellent safe surgery without, and having that skill set for there. I think there's a real aspect about remaining calm and motivated when there's just an insurmountable situation like you're describing in Gonda, which we wouldn't be having on routine sides the same. I think there's a lot of waste in healthcare in high income countries, lots of disposables. I look back at the bags when I finish an operation here, and all the plastic bags of waste that is then thrown out, from disposable drapes to all the screw packets to everything else. And I think we just still need to be able, I think, to really, when you're going overseas, to be totally open that there's another way of doing things. And the people that you're working with are many will be really exceptional clinicians and surgeons. And I think also there's some amazing examples the way things have developed in Africa and how that's gone around the world. Take Uganda. So there's a cure hospital in Uganda where in that region of Uganda, there's some of the highest incidence of post-infectious hydrocephalus, or hydrocephalus is an English one, and the typical treatment would be putting a shunt in, the shunt in here, ventriculoperitoneal shunt under the skin, and then draining the extra fluid, the extra cerebral spinal fluid off. And that was the standard treatment. But the problem is that if it's a post-infectious cause, the rates of infection are higher. There's malnutrition. And so shunts aren't great. And if the shunt blocks, then that can be an emergent situation. And that child could be a long, long way from a neurosurgeon who could take care. And the team there developed an operation called the endoscopic third ventriculostomy, where they widened up two of the channels in the ventricles in the brain. They widened up that narrowness, which got furred up by the infection. And then they also slowed the CSF flow, the cerebral spinal fluid flow, by reducing some of the output. And actually that was fantastically successful, and they refined the procedure over the years. And there are still some children who do need shunts, but many can be shunt free from this surgery. And that became a centre of training, and people coming the world over to learn how to do that technique. And since that technique has now gone all over the world. So I think there's some amazing kind of, I don't know, reverse image innovation, I don't know if that's the right term, but just amazing innovations that can happen in Africa, that can go around the world. I think a lot we can learn from dealing with complex late presenting pathology that we just don't see in this level in high income countries. And actually, with the way that we live in a global society, people are traveling around the world, and they're turning up to, I'm living in Toronto now, and it's an amazing, multicultural, fascinating city, but we're having children and turning up with very late presenting pathology. And actually surgeons are now having to become well versed in this in a way that it would be part and parcel of your normal care in Ethiopia, Ananya, but very unfamiliar here. And so I think there's a lot that we can learn. And of course, coming back the other way, there's ridiculous computer systems whereby it's just trying to figure out the computer system, gave me even more grey hair when I arrived back in, and I did miss paper notes, but I can see the benefit of it now. But there's certainly some getting used to healthcare here as well. And but I think it's the transition in many ways is harder coming from a high income to a low income setting. I think there are many more things to get used to than the reverse.
Yeah, that makes a lot of sense. I think one of the things that always surprises me in a way is, especially in high income countries, because most expenses are covered by insurance. And unlike, for example, Ethiopia, it's out of pocket. So is the, that's the reality in most African countries, it's out of pocket. But most of the medical decisions are not made by the physician or the surgeon. It also has to be approved by the insurance. Mm-hmm. So I always say to my colleagues, we got it good, because we can, in Africa, I can see a patient and say, you know what, I'm going to operate on this patient. It needs a surgery. And as long as I think I have the equipment and the time for it and the skill, I can operate on that patient. There's no other body coming in and say, oh no, you can't be doing that because we don't think it's medically necessary. So I don't know, but I think that is a huge privilege that we have, especially in Africa, as surgeons, to have that autonomy, which I think is not so much fun in the high income countries. Mm-hmm. Mm-hmm. So you've worked in centers of excellence like Cure, even Sick Kids. And how can we scale this sort of centers for excellence across the regions facing resource constraints? And how can we balance excellence with access in such environments?
Mm-hmm. Yeah, that's a very, very good question. I think taking Cure is an example. I think the world of the organization, and just for the quality of care, I know really just the sort of gospel-centered care that is through everything that is being done, and just having each and every patient trying to provide, having a no compromise attitude to the care that child would receive. And that is all in a hospital that is dovetailed in with the government system in a way that trainees come to and fro. It's easy referrals. And I think that system works in a really great way. And in some ways, Cure, I've heard the term sort of niche hospitals, and it kind of makes sense. It's a niche hospital in the sense that it provides orthopedic surgery and plastic surgery. And so then with our colleagues in the government sector, they would see a child with a burn contracture or with a dislocated hip, and they could go, well, actually, we don't have the capability of taking care of this child because we were overrun by trauma, but send them along to Cure and they'll take care of that child. And actually we'll send the trainees there as well to build their experience in that area. And I think that works really, really well. In Addis, there's the Fistula Hospital, which is just an incredible institution. I mean, you'll know it well, Ananya. So Catherine and Reggie Hamlin set that up, I guess it was in the 60s or 70s, for women who had obstetric fistula. And of course, you're talking about vulnerability. I mean, the poor women who are often young women, and they've been through obstructed labor, and their babies died, and many of them will die in the process. And if they don't, then the pressure of that baby's head on the back of the rectum and the bladder neck causes that tissue necrosis, and they end up being incontinent and actually being ostracized from society just because they're leaking and they can't remain themselves clean. And the Fistula Hospital really created just to do surgeries for these women. But alongside not just learning how to, or not just teaching people how to do these surgeries, but also setting up a midwifery scheme. In the same way as we're doing fellowship training for orthopedic surgeons, they were training midwives in order to provide safe maternal health care to a level that those rates of fistula are now coming down so low that hospital needed to diversify. There were not enough obstetric fistula, I think, coming through, and needing to diversify in other gynecological aspects, in an amazing example of not just dealing with the condition and taking care of these women in an incredible way, but also being a part of the prevention. And so I think within all of that, I think niche hospitals like Cure and the Fistula Hospital can be part of early recognition and prevention as well, and be centres of training. And I think so long as we're dovetailing in with the government sector and working alongside colleagues, that can be a really great example. But I think training is a key aspect to make this work. Sick Kids is different. It's an incredible institution, but it is government funded, and all the children from around the area, they come through to Sick Kids, and we have amazing people working here. And that's all specialties. But I think in some ways it's the NGO hospitals which can take care of one section of healthcare society or the healthcare spectrum, that can be a really positive thing.
Yeah. So just collaboration, I think, is what you're saying, right? Yeah. Okay.
For sure. Every step of the way.
Yeah. Oh, wow. Okay. So you're a pediatric orthopedic surgeon, but you also see complications of trauma as well, even if it's in children. And there's a obvious data that supports the economic burden of trauma and its associated morbidity or mortality, but we don't see, and not just that, but other orthopedic conditions as well. But we don't see a lot of orthopedic surgeons involving in global surgery. What is the role of the orthopedic surgeon in this conversation? Do you think the orthopedic surgeon should just focus and do surgery and one-to-one patient care, or do you think we have a bigger role?
Yeah, you're going to be best off answering that, but I'll have the first crack. I think as an expat surgeon working somewhere like Ethiopia, our role is really providing the high standard of care that we're able to, and working alongside colleagues and helping support training. I think for a national orthopedic surgeon, an Ethiopian orthopedic surgeon who's working within the country, I think the power that you have for advocacy is huge. For you just advocating at the highest level of saying, goodness me, I'm having soldiers coming through who are multiply injured and I'm on my own and I can't cope with the volume, and actually advocating the highest level of just saying, look, we need resources, we need infrastructure, we need investment in all of these areas. And so I always saw my role as being a supportive one, but then seeing yourself and other colleagues actually taking a central role, doing amazing things really on a broader public health measure, whilst also holding down a clinical practice. What are the needs at the moment? I think in many countries where patients are still having a very hard time of access, children's healthcare to some degree, but I think spine surgery, the investment needed for that is huge. Tumor surgery on the kind of oncological aspect, very late presenting tumors are coming through, and maybe there isn't the awareness of early recognition, and then even the surgical access to care and the chemotherapy and the radiotherapy. Gosh, Ananya, I remember seeing one of your posts talking about traditional healers and the injuries that we're seeing from sangomas, from traditional healers in many parts of sub-Saharan Africa, with people going straight to them and having very tight bandages put on and getting these awful contractures, sometimes needing amputations. And then how on earth do you get to a point of sort of bringing them in to a point of providing safe care rather than criminalizing the procedure. I wouldn't know where to start with that. But it's that aspect, as being the orthopedic surgeon, seeing children coming in who may be injured by some of these aspects and then advocating for that. I think that, you're by far the best place just to see the suffering by any one of these conditions and then advocating for that at the highest level to foster change. What would you say?
Yeah, I mean, I agree with everything you said. I think obviously as surgeons, we need to understand that our role goes beyond those four walls, whether it's the clinic, whether it's the theater. Um, and, you know, you mentioned about traditional bone setters, or, and then we also have the other one, right? Traditional healers and stuff like that that don't do bone setting necessarily. But if we really look, this is where cultural context is very important, because our the healthcare seeking behavior of the population you're treating matters. So if the patients that we have no problem traveling days to go to a traditional bone setter versus a hospital. Now, it's very easy to say, the traditional bone setter is next door. That's why they go there. But is it? Because when you look at it, people pay a lot of money. I've seen people pay a significant amount of money to be treated by traditional bone setters rather than coming to a hospital being treated by an orthopedic surgeon for free. So that's where the question should arise. What is the actual problem? Is it necessarily access? Because that individual, the traditional bone setter, is also far not accessible per se, and they're paying a lot of money. So it's really about the attitude. For me, how I understood is the traditional bone setter is part of the community, right? It's somebody next door, or somebody next door is testifying for that person. So they're very familiar. But us wearing white coats, and we're educated for how many years, and we don't even speak the same language. When I work in Gondar, I'm speaking Amharic, they're speaking Amharic, but our Amharic is completely different. So even speaking the same language, we didn't necessarily understand each other all the time. So you see all these layers of differences that can cause the population you care for to look at you as someone who's not part of that community, right? And so I think as surgeons, to advocate for proper patient care and teaching patients and empowering patients with knowledge is important. And how we do that is taking off the white coat, dressing like they do, just going there into the community and doing teaching and teaching the community, not just teaching residents. Yes, you need skilled manpower, but also patients need to come to the hospital realizing that service is better than the service or the care that they're going to have that's going to result in horrific complications. So our job should be going into the community, and we shouldn't shy away. Yes, publications are fantastic for ourselves, prestige, right? But how much of that data that we're publishing is actually being implemented? That's a different thing too. Like, that's a question on its own. So I think we need to start looking at it from a different angle and really understand the cultural context of the patient population that we have. And one of the things I've noticed in Western countries are people are very aware of their health. They can just go on their phone and Google. Yeah, Google tells you everything is cancer at the end of the day, but at least there is some information, some free health information available, which you can't find, for example, in the Amharic language, right? So one of the projects I did was a free basic health information website. I did it out of pocket. It was just a passion project that I've always wanted to do. And I started with maternal and child health because it's two birds for one stone. You save two lives. So it's in the Amharic language. It's very simple because sometimes you can't use Google Translate for everything because the cultural context don't hit the same way. Some words with Google Translation have no meaning in the Amharic context,
Yeah.
So it needs that input of us, the surgeons or the doctors who've been trained to bring those two worlds together of the population we're treating, and then the, you know, the knowledge and training that we had from the adopted from mainly from the Western world. Um, so yeah, that's me. That's just what I think. I don't know. What do you think?
Well, no, I think that's a great example of why, nationally driven programs to really understand the cultural nuances of that. I think the traditional bone setter aspect is urgent and super complex, and I think that your strategy there makes so much sense. And I think in some ways you mentioned data, and I think it's probably both and, isn't it? Because you need the data just to know how big the issue is and to be able to advocate for that change. And I think that your way of approaching that is very, very wise. One of the things that you'll know from the Cure Hospital in Addis Ababa is children born with dislocated hips, so DDH, hip dysplasia. So much hip dysplasia in Ethiopia, and yet, you know, I could show you half a dozen papers to say there's no hip dysplasia in sub-Saharan Africa, and that's clearly not the case. And trying to be a part of the solution there. I mean, what do we do about that in order to identify children early who don't need to have their hips opened up age 4 and femurs, thigh bones cut, and, you know, shortening done, and pelvic osteotomies to recover in like big 4-hour surgeries, which might be another 4-hour surgery 4 weeks later to the other hip. All of that morbidity, when if you identify the child in the first few months of life, they can be managed in a Pavlik harness or a type of sling. And going through we're in the midst of a big screening campaign. We screen, I think, 1,500 children so far, and trying to understand the incidence of the condition. And actually, that's been a journey itself, trying to get quality ultrasound scans to try to understand. But in some ways, the data seems to be important, because only then can we advocate with the Ministry of Health and say, look, this is how common the condition is, and we can treat it successfully if we can identify these children early. And actually, this is so worth investing so we can screen these children and identify them. And so that data point, I think it is a both and. It's dealing with the issue as the advocacy, but that's going to be backed up by some of the economic analysis as well, is probably what we also need to be doing as orthopedic surgeons to help the Ministry of Health make the hard decisions about funding. But yeah, it's fascinating and challenging all at once.
It truly is. That's why I love it, because you can never be satisfied. You can't just never say, oh, I've done my part, because there's always something more to do. And, you know, it drives you to do more things for, you know, your patients. Yeah. So thank you so much, Dr. Rick. It's been an hour. I know you're very busy and you have to go back, but thank you so much for coming on the Everyday Leader for this fantastic conversation. I just hope that people get to glimpse into the kind of amazing teacher, great leader, and just a thoughtful advocate that you are in the field of orthopedics and also, you know, global surgery. So thank you for coming on.
No, Ananya, thank you. It's been an absolute pleasure and an honor. Really enjoyed it. Thank you.